Thrombocytopenia. Thrombocytopenia occurs in many disease processes as listed in box 2314, many of which are discussed elsewhere in this chapter. Idiopathic thrombocytopenic purpura. Idiopathic thrombocytopenic purpura is immune-mediated with involvement of autoantibodies, most often directed against the platelet membrane glycoprotein 2b3a, which sensitize the platelet, resulting in premature removal from the circulation by cells of the reticuloendothelial system. It is not a single disorder. Some cases occur in isolation, while others are associated with underlying immune dysregulation in conditions such as connective tissue diseases, HIV infection, B-cell malignancies, pregnancy, and certain drug therapies. The clinical presentation and pathogenesis are similar, however, whatever the cause of ITP. Now, clinical features and investigations. The presentation depends on the degree of thrombocytopenia. Spontaneous bleeding typically occurs only when the platelet count is below 20,000. At higher counts, the patient may complain of easy bruising or sometimes epistaxis or menorrhagia. Many cases with counts of more than 50,000 are discovered by chance. In adults, ITP more commonly affects females and may have an insidious onset. Unlike ITP in children, it is unusual for there to be a history of a preceding viral infection. Symptoms or signs of a connective tissue disease may be apparent at presentation or emerge several years after. Patients aged over 65 years should be considered for a bone marrow examination to look for an accompanying B-cell malignancy and appropriate autoantibody testing performed if a diagnosis of connective tissue disease is likely. HIV testing should be considered because a positive result will have major implications for appropriate therapy. The peripheral blood film is normal, apart from a greatly reduced platelet number, while the bone marrow reveals an obvious increase in megakaryocytes. Now, management. Many patients with stable compensated ITP and a platelet count of more than 30,000 do not require treatment to raise the platelet count, except at times of increased bleeding risk, such as surgery or biopsy. First-line therapy for patients with spontaneous bleeding is with high doses of glucocorticoids, either prednisolone 1 mg per kg daily or dexamethasone 40 mg daily for 4 days to suppress antibody production and inhibit phagocytosis of sensitized platelets by reticuloendothelial cells. Administration of intravenous immunoglobulin can raise the platelet count by blocking antibody receptors on reticuloendothelial cells and is combined with glucocorticoid therapy if there is severe hemostatic failure, especially with evidence of significant mucosal bleeding or a slow response to glucocorticoids alone. Persistent or potentially life-threatening bleeding should be treated with platelet transfusion in addition to the other therapies. The condition may become chronic with remissions and relapses. Relapses should be treated by reintroducing glucocorticoids. If a patient has 2 relapses or primary refractory disease, second-line therapies are considered. The options for second-line therapy include the thrombopoietin receptor agonist TPO-RA, L-Thrombopag or romiplastim, splenectomy, and immunosuppression. Where splenectomy is considered, the precautions shown in box 2340 need to be in place. Splenectomy produces complete remission in about 70% of patients and improvement in a further 20 to 25% in favorable cases. The TPO-RAs induce response in around 75% of cases, usually within 10 to 14 days. Low-dose glucocorticoid therapy and immunosuppressants such as rituximab, cyclosporin, mycophenolate, and tacrolimus may also produce remissions. The order in which therapies should be used is not entirely clear, although the TPORAs are licensed for this indication while the immunosuppressive agents are not.